I'm David Singh. I'm one of the current outgoing fellows. Picked this topic to chat about today on interaction of the hip and spine, which has colloquially been named the hip spine syndrome. Overview, we'll just look at some literature and then try to describe clinically how to differentiate between common hip and lumbar spine pathologies. Take a brief look at their interaction biomechanically and their contribution to sagittal balance together, and then discuss treatment decisions. Overall, it's a confusing diagnostic picture. Both hip and spine degenerative pathology are common. 50% of patients undergoing total hip surgery report some low back pain at some point. And so there's been some discussion. This commentary was published titled, "Is the hip bone connected to the spine bone?" And they suggested that spine surgeons learn how to read hip radiographs accurately. So prevalence overall, roughly 9% of adults have symptomatic hip OA, and low back pain, similarly, is very epidemiologically, it's one of the more frequent reasons for why patients visit the physician offices in the United States. So huge societal burden and economic costs related to both these issues. So since there's some overlap between hip pathology and spine pathology, it can be very diagnostically challenging. There can be growing pain, which could be referred radicular pain versus intra-articular or extra-articular pathology. Pain that worsens with activity, which could be arthritic in nature or neurogenic. At times, even vascular claudication can be confounding the picture. And then radiologically, there's always some evidence of changes at a certain age, which can be normal, but all of these must be interpreted in this context to identify the pain generator worth trying to chase down. In the hip, there's a spectrum of intra-articular degenerative hip disease, as well as extra-articular pathologies, including the glute medius strains, which we talked about at that research conference last week. So all of these can localize the pain around the hip. Similarly, from the spine, stenosis, spondylolisthesis, facet cysts, deformity, malalignment, all of those can also similarly contribute. And then from a newer standpoint, other less common things like sacroiliac pathology or vascular or neuropathy issues may also localize to the same area. This overlap in symptoms was first described in 1983 and named hip spine syndrome. And they essentially highlighted that anterior thigh pain was very common. It could have been L4 and also overlapping with intra-articular hip pain. So they recognize this as a phenomenon that there's overlap in symptoms. And they're basically trying to describe this in 35 patients they saw. So they wanted to classify it based off of a single versus having a single source versus having both hip and spine as primary issues. And then they named this secondary classification, which essentially has to do with either the low back or the hip compensating for pain from the other source. So this secondary source kind of evaluated, where's if you have hyperlordosis to compensate, do you get facet pain? Where does the radiating back pain and buttock pain come from? And they described it as two connected hinges. So if one hinge is more stiff, then you compensate through the other hinge to maintain your upright posture. A lot of the studies tried to delineate how to figure out where the pain's coming from using a series of injections. So in this study, 51 patients had over 90% relief of their symptoms with an intra-articular hip injection. And amongst those patients that had a positive response, they asked them all to draw on the graph, the picture here, as well as record where their symptoms were that's experienced significant improvement. And the takeaway was the hip joint never radiates proximally, so you don't get low back pain from the hip, but virtually every other symptom distally, from the buttocks to the thigh to groin to the leg, all can occur in some combination in response to the injection. This is a similar one where they surveyed patients. They didn't do any injections, but they surveyed patients who were about to undergo total hip versus patients about to undergo lumbar decompression surgery. So in that preoperative period, while they're waiting for surgery, where were their symptoms? And you can see across the board, and some of these may have had overlapping pathology to start with, but you can get symptoms everywhere in an almost equal amount with both conditions, except for anterior groin pain being more sort of specific for hip osteoarthritis. So that's kind of matches traditional teaching. Difficulty in pinpointing where the lumbar spine pain comes from is that you can't just inject one joint and see, because there's so many different pain generators. So here's old school through discography where they're trying to identify the facet joints and then the intervertebral disc space. And then they would try to probe or ablate these areas to see if there's pain. This Japanese study tried to look at knocking out certain joints in patients who had distributions of pain in the common areas, low back, the buttock, the trochanter, and it doesn't have a single diagnostic distribution with the injections when you undergo the different facet joints. They're highly variable, other than most of the facet joints, almost all of them, when you knock them out, if you're having back pain, seems to provide some relief. But the pain from the facet joint can be referred to these other areas as well. This was a series of 4 patients in Japan that, interestingly, they had relief of lateral leg pain after intra-articular hip injection. So this is their injection, seeing their pre-injection score and their post-injection score going from 6 to 8 down to 0 to 1. So an effective intra-articular injection, but then they didn't have any improvement in symptoms with decompression and fusion. So that's sort of contrary to what you'd think. All 4 of these underwent total hip, and after the total hip, they experienced resolution of their leg pain. So a little bit confusing, but it just demonstrates how it can be hard to pinpoint if it's the back or hip. Here's a few pictures from this study where you can see they had addressed the 4-5 stenosis, which the injections did take care of preoperatively. In the right case, they actually injected the hip, and it didn't improve the leg pain. But after they did the fusion and then the hip replacement, it only got better after the hip replacement. This is a series from Dr. Parvizi, looking at 344 patients, looking at the incidence of back pain in patients who are undergoing total hip. And roughly half of them presented with some back pain. And most of these had some improvement at 1 year after total hip. So kind of suggesting that if you fix the hip, then you have improvement in their compensatory mechanisms and less strain on their back. Interestingly, on the other arm over here, 35 patients out of 174 who presented without back pain ended up developing back pain within the first year. So unclear if that has to do with just the natural progression and they had osteoarthritis, so it was going to start hurting eventually one or another, or if there was some similar compensatory mechanism after the total hip that increased strain on the back. So, this is probably the most convincing study that there's a very high correlation between the two. And then this multi-center study looked at 156 patients with either hip arthritis or lumbar stenosis, and then asked 51 treating clinicians classify the presenting exam symptoms and which pathology they attributed those to. So kind of comparing like a expert consensus survey to the pathology. And the most specific findings was that the growing pain was pretty much unanimously recognized to favor hip arthritis, and with a likelihood ratio of 5. So if you had hip arthritis, they're at least 5 times more confident that it was coming from the hip rather than the spine. And then neurological symptoms like numbness or tingling were more likely to be attributed to lumbar stenosis. And then some of these other common symptoms we ask about, like pain with walking or bending forward, a shopping cart relieving the pain, were a little bit less commonly reported than we maybe expect from the patient side. So less reliable indicators, less specific. So maybe a little overvalued for diagnosing lumbar stenosis. Getting in and out of the car, interestingly, was one that was highly associated with hip pain. And then also putting pants on the affected leg was very highly specific for hip arthritis. Range of motion limited to the hip was also very specific, and neurological weakness was considered to be attributable to the spine. So some studies that basically helped establish how we approach our physical exam between the two. And more recently, the SI joint has become a bigger focus as an additional pain generator. As we know, very comfortably in the OR now how to address this problem with the help of the fan. And the theory behind this is that the L5 nerve root passes right by the SI joint. So if you get inflammation from the SI joint, not only could you cause local pain, but you can get these same radiating symptoms from the L5 nerve passing over that area. Some of the early descriptions of where SI joint pain can refer to discuss pain over the PSIS in the buttock area, that classically called the Fortin's test. And they did experience patients who had injections in the SI joint that seemed to have relief in the groin and the lateral thigh and the posterolateral calf as well. And this is their sort of collection of studies that point out the different areas where this set the hip joint can refer to, and there's all a lot of overlap. So another thing to consider in a very confusing presentation already. From a mechanical standpoint, all of these are connected, and the hip and spine alignments are important to maintain overall global sagittal alignment. And one consideration, and also coronal alignment if you have uneven leg length from hip wear. So one thing to think about is that the hip center play an important role in all our sagittal balance measurements. So changing the hip center of range of motion, whether that be from just degenerative wear and migration of the femoral head versus an acetabular cup placement. Usually we superior medialize the cup a little bit for just in theory to optimize mechanics. But all of these things can alter the sagittal parameters we measure and affect the position of the pelvis in our sagittal assessment. We're all familiar with this cone of economy, which involves the head centering over the hips over the feet. And the concept is you have the highest efficiency of using your muscles when you within this cone, and that it requires more energy to maintain upright motion when you're out of this cone. This was a mechanics paper demonstrating this principle when you have a patient blindfolded and measuring from a force plate their sway. You can tell that with patients with scoliosis who have their balance outside of this cone, the sway measured ends up being much more distributed. So knowing from our EOS scans that there could be contribution from multiple parts in the hips and the standing alignment. This can affect sort of your measurements. But the pelvic tilt has always been, in our minds, a soft indicator of how much compensation they've been going through. And recently, in the hip world, this concept of pelvic tilt has been starting to gain more traction. With the excessive pelvic tilt, the acetabular component may, in the supine position, be put in with excessive anaversion. And so then when they go from sit to standing, it might actually be an abnormal range of motion that can result to dislocation or revision later on. So the pelvic tilt may end up contributing to this overall picture as well. This is very pertinent because dislocation is one of the higher reasons for revision now. But in patients with mismatched lumbar spines based off of the more traditional PIL terminology, they saw there was higher rates in dislocators to have what they called an imbalanced spine. This is just showing dislocation of the hip being 12% reason of revision. This is a little older data. I think the more modern data, the mechanical loosening and polywear is less of an issue. So dislocation has kind of come up relatively even more than in the past. This study tried to measure how flat back contributes to acetabular anteversion. In their estimation, for every 1 degree of increased pelvic tilt, you end up with 1 degree of increased anteversion. And similarly, you get for every 3 degrees of lumbar lordosis, you get 1 degree of anteversion. So, in most situations, you're not going to be dramatically changing alignment. But if they have severe sagittal imbalance and then go through a major reconstruction, that could alter the cup mechanics and the position of cup relative to their standing position. So it could end up retroverting the cup. Traditionally, we discussed everything based off of this Lewinick safe zone that aims for about 20 degrees of anteversion. But again, this was 15 to 20 degrees. But this is kind of been challenged recently because you're only looking at this safe zone placement in the supine position when patients in the operatively on the table on this horizontal horizon rather than when they're standing. So a lot of people are challenging this now of what's the actual functional safe zone versus what is this traditionally described safe zone. So some ways of describing this better is to look at the full sort of hip pelvis spine range of motion throughout different positions. And we kind of think of this too in terms of flexibility of supine versus standing. But sitting radiographs has been something that's been published more recently in trying to understand what is the pelvis doing between sitting and standing. And essentially in the seated position, there's more tilt, more retroversion of the pelvis, and a little bit less lumbar flexion. So when you stand, you get more lordosis and you have a little bit more pelvic, less pelvic tilt. So looking at these different situations, some of the hip replacement mechanics studies have been suggesting that that kind of puts you into four different groups. Is there flexibility in the lumbar spine? Meaning, is it changing between flexion and losing a little bit of flexion between sitting and standing? And then also, that's flexible versus rigid? And then at baseline, is your spine balanced? So do you have like a general flat back versus a fused flat back? And essentially, this paper advocated for trying to do if you have lumbar pathology, to try to reconstruct the lumbar lordosis first to get them out of relative kyphosis prior to placing your total hip. And then if there's some rigidity to the spine, you may want to end up putting your anteversion a little bit higher just because they may not have the same ability to go through range of motion. So positionally, so what happens when you go from sit to stand from the hip standpoint, when you're standing from a seated position, because the pelvic tilt decreases, this uncovers the posterior femoral head. And then vice versa, from sitting to standing, your pelvic tilt increases. So you uncover the anterior femoral head. So there's this functional window of where there's coverage based on your position. So this becomes a problem if there's no compensatory mechanism and there's no flexibility in the spine. So you can be stuck in a always standing or always seating position is how they describe it. So if you're unable to kind of shift, then you may end up impinging in the front with a permanently, posterior uncoverage. And if you impinge in the front, that can leave you out in the back, causing dislocation. So this is probably the most convincing theory as to why fused spines have higher dislocation rates. In the situation with flat back, where they may still have a little bit of flexibility, when you're standing, there's still some increased anterior uncoverage, which may cause posterior impingement and anterior dislocation, theoretically. I think that's less seen clinically. So overall, if you're fused flat, and you have both of these issues, you don't have you're sort of forcing yourself to hyperextend at the hip to stand upright. And so over time, if they're unable to get the hip range of motion to stand upright, you have a sort of flexed posture and you're crouched over. So that's definitely a difficult situation in that way. So overall, there's similar principles in thinking about the sagittal alignment for both hip and spine. So there's more situations in the hip because it's functional range of motion is more. But back when they were fusing hips for arthritis, it was a similar concept of if you have to pick one position to fuse them in, what's optimal, and they sort of arrived at those numbers based on measurements. But in essence, why is this important for us? We don't do hip surgery well. Essentially don't fuse them in a flat back, but also it makes sense to look at their hips, the plan, kind of make a treatment decision in the order of what you want to address to try to avoid issues like this. But from this paper, they said, if they have lumbar sagittal imbalance issues, it's not always clear what to do first. You may have to look at what pathology is more important. Obviously, they don't go into detail about whether they're presenting symptoms. A lot of times, if they're not a deformity patient and it's just a sort of stenotic patient, we don't necessarily try to fix every flat back. And certainly that's not what this paper is advocating to, but maybe this is an indication where if it's a gray area, you may be sort of more inclined to treat the back first. But otherwise, if in the situation where you do have a balanced lumbar spine, if it's flexible versus rigid deformity, your parameters of where your cup placement may be altered. Some of the recent studies are looking at seated X-rays in the flex position to look at the total pelvic tilt compensation. They demonstrated that on average, you change 20 degrees of lumbar lordosis in the sitting position, and your hip flexes about 60 degrees. So basically, if you can't get 60 degrees of flexion through the hip, if there's a contracture, that ends up causing more strain on the low back. And if you don't have 20 degrees of lordosis in the low back, then you try to get more hip range of motion to compensate for that. And so I'm trying to understand this relative to hip replacement theory. This paper looked at how does the anterior pelvic tilt change, resulting in the change in position when standing in your anteversion. So for every 13 degrees of tilt that you're standing on, you get about 10 degrees of change in your cup anteversion. So they're sort of advocating if you're anteverted, you want to, if you have excessive pelvic tilt, you may want to antevert a little bit more. If you have less pelvic tilt, normally you may want to end up retroverting a little bit more. It was looking at 4,000 patients, both looking at their supine and seated images. They defined a group of having unfavorable spinal mobility, spinal pelvic mobility, which was patients with less than 20 degrees of lumbar flexion, change in lumbar lordosis between seated to standing. And then they looked at that subgroup and found a higher rate of dislocations. So they advocated for changing their cup parameters. This study looked at 6,000 primary total hip patients that also had all of them had spinal pelvic measurements preoperatively. And they again defined stiff spine as less than 20 degrees of flexion between standing and seated. And 6% of the patients overall were considered to have a stiff spine. But interestingly, so still a relatively uncommon problem for them, this 6% of patients who can't compensate at all. But out of that 6%, only a fifth had prior instrument infusion. So most of these stiff spines are just patients with degenerative stiffness, not necessarily something that comes from the spine surgeon. So it's not overwhelmingly a huge problem that we have to consider, but we'll come across it. So shortcomings of this study, they didn't specify how long the fusions were, and ultimately they suggested screening, but it's unclear what parameters or what X-rays may be helpful to look for this stiff spine in that setting. And also, they don't know how many number of levels were fused, so theoretically, a 4 or 5 fusion versus a 2 to 1 fusion is going to act very differently for them. This is just a case scenario of a patient who got their reconstruction for flat back, degenerative flat back, and how the cup anteversion changed. So it went from 17 to -3 degrees, so almost a 20-degree difference in the anteversion. So you can see when they're standing there, and picture C, how you can interiorly impinge when they're sitting and pop out the back. So definitely something to look for. Probably more of a consideration when doing three-column osteotomies. Then transitioning to sort of the large payer databases more recently that have kind of pointed out this trend from a more macro scale. This is a Medicare study demonstrating higher rates of dislocation in patients with previously fused spines, with longer fusions of 3 to 7 levels fused, having even proportionally higher rates than shorter fusions from 1 to 2 levels. So overall dislocation rate of 1.5%, and that bumps up to 3 to 4% with fused spines. So still, on an absolute scale, not super common, but on a relative scale, a large increase. This is a similar study looking at a different patient population with the Humana database, or a portion of private payers. and they also demonstrated higher dislocation rates. They tried to stratify by if the hip was done before the back or if the back was done before the hip. And their conclusion was that there's a higher revision rate and dislocation rate in the patients who had the total hip done first. So they advocated that in a situation where you have to decide, spine should be done first before the hip. This paper showed the exact opposite, looking at Medicare database stratifying by which one was done first. So they analyzed the dislocation revision events and showed that doing the hip first had lower dislocation. Their conjecture was that if you have the hip done first and you have good bone ingrowth and you have stable soft tissue healing and scarring, and then rehab the hip, that might be better to have a more stable hip rather than doing all that and then fusing after that to not affect the mechanics too differently. So I don't know, that's a little simplistic explanation, but overall they saw higher rates in doing the hip after the spine. So all these administrative databases are good in giving a overall picture of what's going on and trends that you see over time. But they don't really tell us details that matter, like the difference in lumbar flexion or their standing alignment and pelvic tilt when they're starting. All of these can influence the dislocation rates. These are only hypothesis generators of things to look for, things to look at, consider. So overall, it's a difficult picture. There's a lot of patients with degenerative hip and spine disease, but a probably very small subsection of them have enough disease to cause mechanical compensatory loss that ends up being a problem with the back or operating on either or. There's definitely confusing evidence about what to treat first. I think traditionally we're sort of more focused on what is the more primary disabler and teasing that apart. I think that's still a solid way of approaching the problem. But depending on what study you look at, there is higher rates of dislocation after before lumbar fusion or after lumbar fusion. So that's something that it may be worthwhile to point out counseling the patients when we know they have hip replacements. I personally haven't seen any of these issues of this year, but certainly in medical school or residency, there were definitely a few cases where it was very dramatic, like the patient popped out, within a few weeks after the lumbar fusion. I think the other interesting thing is we put so much weight into pelvic incidence because it's supposed to be a fixed measurement, but this almost makes me wonder if sort of was there functional pelvic tilt, if that's something that we should focus more on in terms of classifying and trying to get a sense of what is their maximum, like how maxed out is their pelvic tilt in compensating. We make the pelvic tilt measurement, just as they're compensating. But like at what point do you run out of that and start flexing your hips? The interaction of that might actually be a spectrum of how much, a meter of compensation that may actually help guide if you want to, err towards undercorrection or overcorrection slightly relative to what their hips are doing too. So maybe there's, or maybe a functional hip range of motion without any degenerative disease could point out something could point out how much correction is needed in the spine too. These are just things to think about. I think there's a lot of excitement from the basic science mechanics on this topic now. Every year in the hip conferences you're hearing there's almost like a section for this now in the spine NAS as well. I think that it was focused, but we'll have to stay tuned for any sort of large conclusions that affect the way we manage these patients. Thanks.
I think it's I've seen a lot of people now that because we bounce each other back. It's the hip, it's the spine, it's the hip, it's the spine. I see a lot of people after the hip replacement who come in and be like, my back hurts, or I have this leg pain. And it's usually like within the first couple months.
Mhm.
I'm like, look, like you're different, right? Your alignment's different, your muscle tension's different, your medius is different. You got to give it time to kind of get reacclimated to your new body, you know. So it's just something that I feel like anytime you change your base, right, your knee, your ankle surgery, your hip, yeah, everything above is different. So you got to give it time to kind of figure itself out.
Especially with like length stuff.
Yeah, like yeah, right. You lengthen them, you shorten them.
They like get pitched off. Like I feel like it depends on the curve specifically, and if it's into or away from. Like I feel like some get pitched off in the wrong direction more though, and like it throws them into decompensation.
Absolutely.
I think the language historically is like, is it the hip or is it the spine? And I feel like more often than not, it's some combination of the two. And even like thinking about adjacent segment disease, like this year, I feel like I remember with Dr. Eastlack, he was like, he operated on a mom and a daughter like in the same week, and then like two cousins at the same week or like a week apart. And their backs looked so similar, like, you know, on different spectrums of how degenerative they were. But I feel like same thing, like you see certain people with just poor quality cartilage genetically, and they'll have, you know, two hips and two knees and coming in for the spine. So a large part of it probably is also just that they're going to continue with their aging process. And when you fix one and you get more problems in the back, it could also be just them crapping out at other levels too. So all that, you know, I feel like the isolated hip joint or isolated lumbar spine disease process is a different scenario than a patient where you see like vacuum discs at every level. All right. Well, if there's no other questions, we'll continue on, and hope everyone has a great day.
Thanks, David.